which will lead to the frontal. This patient did not have one on the other side, but there is a frontal on this side, as we've now just seen. So this is what you should do first, and then we will show you how to resect and approach the uncinate process. And here again, a demonstration of an accessory ostium, how it is not behind the uncinate. And why is that an accessory ostium? It is perfectly in the vertical plane. Natural ostia always have a tilt of some 15, sometimes even 20 degrees away from the vertical. So you can see that in this specimen a little later. So, okay, have fun and enjoy, and I would ask the instructors to tell me once you're through with that. Und der Herr Hasser kann mir vielleicht den Ultrastoppler wieder heraufzaubern, das habe ich leider vergessen. Okay, we are still working with the 0-degree telescope. Let me just see what the focus has done in the meantime. And Standardlöffelchen, die Jakarta, please. Okay, so to familiarize ourselves again, middle turbinate, no trauma. At the end of your surgical procedure, there should be no injury to the mucosa of the middle turbinate. I know that's academic postulate, depending on the quality of the cadaver. But in reality, in a patient, you should not have a bruise at the middle turbinate here. Okay, so still tiny remnants of the uncinate superiorly, but we see the maxillary sinus ostium. Here we had connected an accessory ostium with the natural ostium. We managed to not touch the mucosa here, so this posterior margin of the maxillary sinus ostium has natural mucosa. We're taking away the bulla, and we now will, as the next step, identify the posterior end of the middle turbinate, follow this bony layer anteriorly. This, therefore, must be the horizontal portion of the basal lamella. Where this swings up, this is the basal lamella frontal portion. You see the defect here, which we have created when resecting the bulla. So this was one of the situations where the bulla did not have a posterior wall. So then the bulla sits on the basal lamella, and when you take away the posterior wall of the bulla, you are through the basal lamella already. So there is no retrobullar recess. Okay? There are little remnants of the bulla superiorly. Once again, you identify the posterior end of the middle turbinate, follow this from the back to the front. This is all posterior part of the middle meatus. And identify this edge. You can see it and you can feel it. Sometimes you feel it better than you see it. And you go 3 to 4 millimeters above this edge. You now go through into posterior ethmoid, through the basal lamella. Before, in Blakesley ganz normal, before you take a hearty bite there, make sure that you identify that there is a lumen. You may choose this instrument again. I always like to see that I am right. And now, like you've seen with circulär gerade, like I did on the other side, you may wish to use whatever instrument you have to create a larger access to posterior ethmoid. Make sure that you do not resect this portion over here, because this then will give you a total, das gleiche in groß, a total destabilization of your inferior, of your middle turbinate over here. So in that case, I use this instrument, and the advantage for me is, see, now I'm biting to the left and inferiorly. Now I'm biting inferiorly. Now I'm biting to the right and inferiorly, to the right and up, right to the top, etc. And I did not once had to move or rotate my hand. Okay. Now, Grabenbeil bitte. We are in posterior ethmoid, and this is about the time when we try to identify skull base first. Okay? You see, we've pushed ahead of us the mucosa, and now this is the true area we need to talk about. Don't pull, because then this will happen in a patient. In a tumor patient, this may be necessary, but in reality, this should be avoided by and large. Löffelchen weiter. So now we have gone through the basal lamella of the middle turbinate. There is another area of bone which we will meet more or less frontally. Which is this now? It's the basal lamella of the superior turbinate, which always sits on the orbit that we start to see here. So that will be the next area we need to go through. And you see it's thin like ice, and I go medially and inferiorly. There's the next layer of bone, which may already be the anterior wall of the sphenoid sinus. It is usually here that for the first time you can expose skull base up there. Okay, but first let's go further posteriorly. For your information, try to find the space between the middle turbinate. I did not create it. This is a natural gap. Middle turbinate, and this is the superior turbinate. Okay? Can you see this? This here is sphenoethmoidal recess. Very careful that you don't resect this, because this will be the end of the stability of the middle turbinate. Now let's go further posteriorly, and you can beautifully start to see already the medial orbital wall. See how this bulges medially, slowly, so don't go there, because then you will kill the optic nerve. If you go to sphenoid or another individual posterior ethmoid layer cell, always go much more medially and inferiorly. So in this case that I'm on the patient's left side, I aim for 7 to 8 o'clock when going down there. Die kleine zirkuläre Grabe nochmal. Now, open it, and again, in a real patient, you would only open this if there is disease. This is by no way a routine step of any surgical procedure, but it may be required, and if so, it can easily be done. So here we are, and that looks very much like sphenoid already. And how big do you create the ostium? One of the most frequently required or asked questions. You cannot answer it. The question is wrong. It all depends on the individual disease this patient presents. In reality, without navigation, if you're in doubt whether this is sphenoid, what can you do? Here it is very clear that this is sphenoid. You see the carotid shine through. Up there is optic nerve, etc. But try the following. Löffelchen bitte. Look for, but very gently, don't fracture the turbinate. Go medial to the turbinate. We have seen there is this excessively large sphenoid ostium. Put in the instrument. Look there, and now it waves hello. If you would not see the sphenoid ostium, okay, somewhere you would put your instrument there. Sorry, just listen. You put your instrument there. You mark the instrument at the anterior nasal spine, like I do now, okay, with my finger. You go out. You bring that under the turbinate until you hit your marking again, and now you understand, yes, this is sphenoid sinus. It's exactly the distance to the anterior sphenoidal wall. This is another little trick by which you can do it. Once you are there, you should take a 30-degree telescope and try to look around in the sphenoid sinuses. You will all see the individually varying anatomy of your specimen. This is 30 degree now. Okay, bring the instrument in. Gently bypass it. Now you can see the bulge of the optic nerve. You can see the carotid artery. You can see the intersphenoidal septum, the floor of the sella. You can look down. In that ridge, you might sometimes see, oh yeah, at the floor you see the Vidian. Can you see that? At almost 6 o'clock now. And I will now rotate over, look for the lateral recess. Some of you may have 5-2 exposed, etc. When you've seen that, Löffelchen, noch einmal, da ist es. When you've seen that, try the following. what in real life you should never do, of course, but here you should. Get an impression for the thickness of both. Look how stable the middle turbinate is. This will neither medialize nor lateralize. It is all in your hands. Okay, so up there you see the bulge of the optic nerve. So careful when here. This is the lamina papyracea. And those of you who know Latin, papyracea means paper thin. Why have our grandfathers called this the papyraceous lamina? Oops, look at that, I'm through already. And behind that we have the medial rectus, superior oblique, and of course optic nerve. If we have time, or we will show it in the clips tomorrow, behind that you will find the optic nerve. So optic nerve continues up there. But let's look for this strange bulge here. And, well, the bone is sick. Luckily the bone is sick here, but I'm sure some of you will find exposed carotid here. So this patient is relatively safe. But you test the carotid, you might break into it. Up there, clearly visible optic nerve. Okay, that's your next step. And after that, we will follow skull base from the sphenoid into frontal sinus. And this then will be the end of the dissection for FES, and Professor Mokri and myself will then demonstrate the approach to the pituitary and beyond towards intracranially. Okay, so enjoy. Artery, but the bone is too thick. We've identified the lamina papyracea over the tip of the orbit, and it's really thin like ice. And we said behind that, here would be the level of the annulus of Zinn, orbital apex, medial rectus, superior oblique muscle. Now, this is the planum. We need to identify the roof of the ethmoid. And here we go in continuation, very gently, from the back to the front. Why from the back to the front? Because the roof of the ethmoid gently slopes up when we go from the back to the front. Would we go from the front to the back? It slopes down, and then there is a certain tendency of breaking into skull base and through skull base. And of course, this is not the way we would like to say hello to our neurosurgical friends. Upturned. Yo. Perfect. Nurse Michaela is improving. So the big danger at skull base in the ethmoids is when you turn medially next to the lateral lamella of the cribriform plate. Okay, upturned standard Blakesley. In reality, aufgebogenen normalen Weil, ja. In reality, this is what you should avoid, but for the sake of anatomical display, permit me to strip that mucosa here. It makes anatomy easier to understand. Now, you can see the transition of the planum sphenoidale into the ethmoidal roof, and there is no need to routinely resect all that, but all that depends on the degree of pathology up there. Okay, and there you can even see the posterior ethmoidal vessels and nerves branch over. In reality, this is a situation you will rarely encounter up here. Okay, optic nerve, you can beautifully see the contour on its way towards the chiasm. Skull base up here. Now we are at level, and I'm coming from the back to the front. My lateral margin is the lamina papyracea, that is the medial wall of the orbit, and whether or not I will resect those subsegmentations entirely depends on the pathology of the very patient in front of me. There is no standard, routine, total, whatever ectomy. Okay? So I followed skull base, identified it now over posterior ethmoid, and now I will start to go into anterior ethmoid. How is it that I know that this is anterior ethmoid? Well, this is why we have left behind some of our lamella. Look, this is the resection line of the uncinate. Everybody agrees? Then the next resection margin is the one of the bulla. Then the next is of the basal lamella, and if I'm behind the basal lamella like here, this is posterior ethmoid. This, therefore, is anterior ethmoid, and the basal lamella here stretches far posteriorly. Aufgebogen schneiden, bitte. Now that I see anterior ethmoid, posterior ethmoid, and assuming there is need to resect this, I can feel behind here, I can see there, and I can start to remove that. In that case, I have selected a through-cutting instrument. But again, this is totally up to you. If it's a thin bone, you might well use to do that with a shaver. However, I've not looked at the CT scan here to see the position of the anterior ethmoidal artery. We will show you tomorrow how on each and every CT scan you can identify the position of the anterior ethmoidal artery. Knowing that this, however, is basal lamella, we know that we cannot have the artery anterior to the attachment of the basal lamella unless we have a middle ethmoidal artery, which is one of the many variants possible here. So you see, I'm not totally at level, but I could do so. But don't forget, no need for it. Posterior ethmoidal vessels, ethmoidal skull base, medial orbital wall, and now we are looking up, and we need to find our way up to the frontal sinus. On that side, it's different from the patient's right side. And it's difficult to give you one recommendation how to do it, because it may be different in all of your cadaveric specimen. Gerade, zirkulär, groß. So let me first try what I would do in this patient, and that is now resect this portion here. What is this? It's uncinate still. Correct. And now I need to determine what is it the uncinate is doing up there. Löffelchen nochmal. There is still a tiny piece of uncinate. I'm still with 30 degree middle turbinate. This is uncinate, and I've now taken away a little bit, and I'm just about to determine whether or not there is a superior blind, a so-called terminal recess. There is one layer above it. Zirkulär gerade noch einmal. So I need a somewhat better approach. You might decide to go for one of these axillary flaps, but again, I think by and large they can be avoided, which is nothing against them, but I don't think this is something which is routinely required. Okay, jetzt das gebogene Löffelchen. Now, what can I see with 30 degree? How can I find my way? I'm trying to avoid punching around or taking, good morning, or taking a drill. A drill as a routine technique is disaster in that field. You will automatically cause a circumferential lesion. Drill out procedures are extremely good operations, but they should be reserved for the handful of indications there are. This is not a standard approach. You cause more damage than benefit if you use it in a virgin case. Okay, orientation, uncinate process, going over, but this is uncinate, we've just been resecting, so apparently there is a blind, and up there we have a cell. Is that frontal? No. So if there is a superior blind, whether this is Aganasi cell or whether this is a terminal recess, for your surgery is totally irrelevant, just names. But you must understand the principle. If it's Aganasi and or a terminal cell, terminal recess, your way up is always between the middle turbinate and this structure. So you come from medially towards laterally, and you come from back to front. Let's try to do that. And I'm still with the 30-degree telescope. From medially to laterally. Interesting, huh? More openings. And from the back to the front. Weil aufgebogen schneiden. Now I see skull base behind. Okay, nothing can go wrong there. I see anteriorly. I'm away from the middle turbinate. The critical area is if I would bend towards medially too much. Now I can resect that. I can safely resect that. Nothing can go wrong here. There is a remnant of the uncinate. You see, I do not resect the axilla because that helps to stabilize the turbinate. And this now is about the moment that I would love to switch to a 45-degree telescope. It would work with the 30 as well, but I prefer the 45. And let me see if I can get the lateral one. No, that's it. Then this must be correct, the lateral one. And this will be the most difficult part of your surgery. And this is the part of surgery where we can create the greatest damage to our patients. It is mandatory, therefore, to remember that opening of the frontal recess and sinus are not routine procedures which must be performed in each and every patient. "45 degrees pointing up changes a bit. Jetzt bekomme ich diesen 60 Grad gebogenen Löffel. Den schwächeren der beiden gibt es einen mit 90, das ist der 90er, eine Nummer schwächer. And now you have a beautiful view up. What is it we can identify? We have had our attachment of the basal lamella, of the bulla. Then somewhere anteriorly there must be the anterior ethmoidal artery. It is either where the bulla lamella points towards skull base or where it reaches skull base. We have something that goes up here which is blind. Is there a name for that cell? It is totally regardless. There is something that could be a remnant of the terminal recess. Now, we are still working from medially to laterally. So this is the structure which could be a remnant of the bulla lamella from medially towards laterally, from the back to the front, very gently diving underneath. And could that be frontal? Let us see. Zirkulär aufgebogen klein. The small upturned mushroom is one of the many possibilities you have. Pulling here would be, this is die Giraffe. Pulling would be a very bad situation up there. Okay, and whatever you do up there, do it under direct vision. There is no need to routinely enlarge it. Usually, if I have patients who suffer frontal sinusitis, either in history or at the time of surgery, I would like to see the ostium level and then decide on what to do. Vielleicht haben die Stürze ein zweites aufgebogenes Zirkulärstandsel. It's a lateral 45, and you have a marvelous view up there into the frontal sinus. See the roof already, some debris in it. And if you, die aufgebogene Zirkuläre noch einmal, if you need to create a wider opening, you may do so. So a so-called draft 2 procedure, taking all of the bone away between the lamina papyracea of the orbit and the insertion of the middle turbinate, can well be done. So I have just performed with 2 or 3 bites a draft 3 procedure. Would you like to create a wider opening? And at all of the circumferentia, the mucosa is still there. This is a significant difference to drilling. Drilling is great, but it should never be a routine procedure, especially not in the frontal. Now dieses gebogene Löffelchen noch einmal. Now let us have a look for the anterior ethmoidal artery, which we do not routinely expose, but let's see where it is. Should be there. Normally, if you look from inferiorly and you find the artery, you may see something that goes up a fovea, which is usually the way into the supraorbital cell. And the next pit anteriorly is the one that takes you to the frontal. So let's see if there is another cell layer behind, and there we have. It's not very pronounced. Normalen Weilauf. Oder jetzt zu einer von diesen Giraffen. Vorwärts, rückwärts, bitte. So let's take one of these giraffe neck forceps, and here again on purpose I remove the mucosa. You can look up here, and this is a very tiny area, but Löffelchen noch einmal gebogen, habe ich hier. As I don't see the scan, this looks very much like another layer, but here it becomes critical. You see the skull base swings up and you could run into skull base proper. So in here somewhere the anterior ethmoidal artery must be located, and there it is. This is the canal, the typical oblique course. I think you can beautifully see that. And if you look from inferiorly, the first pit up is a small supraorbital recess, can be a large one. Then it's the frontal, aufgebogen schneiden noch einmal. And now you may decide, but that depends on the individual pathology. Oops, wrong nostril. You may decide to resect this. No danger in doing so. The anterior ethmoidal artery is posterior to that. You can see it very nicely. So you may create a smooth level, but you should not strip the mucosa in that area. Okay, for the sake of time, I think I would stop here and then leave it to you to further go up. So here we have a beautiful example of a frontal, possibly with a small osteoma in it. Could well be, but that osteoma doesn't cause any troubles. But we will talk about that tomorrow. And you see the oblique course of the artery. So at the end of it all, 45 degree, we have performed a total sphenoethmoidectomy. We have left untouched the middle turbinate. It is as stable as it was in the beginning. It does not have any mucosal damage here. There is no risk that this will lateralize, and we have had a nice view into maxillary sinus with all the structures, and I've given you a view with the 70 degrees this morning over on the other side. Okay, and you've seen the sphenopalatine artery. Should there be time, you might try to find it, but I think we're running short a bit of time. Okay, with that in mind, back to your specimen and enjoy. We will, in the meantime, change the cadaveric specimen, and Professor Mokri and myself will get ready to demonstrate the rhinoneurosurgical approaches then. Thank you very much. Schwester, hervorragend. Tiny drill, but that's the only one available here, so that may take light years for us to do.
Now you see why we didn't want to use the drill, because the fibris covers everything.
This is way too small a drill for the purpose. So all we can show is the principle. And you lose an enormous amount of information once you start to use the drill. Luckily, the bone is spongiotic. It is thick, but it's spongiotic. In reality, I would not work if I have such a poor vision, but again, as this is a cadaveric specimen, I dare to do it. So why not? Could you irrigate and aspirate things. Yeah. It is difficult for us here, not to have an excuse, but more difficult than in reality. Anyway, there you go. Irrigating the debris. See the fatty eyes on the fluid now? That's from the bone marrow through which we have drilled. Why not have a second aspirator and crisscross that? So he doesn't have to use cleansing and we have to wait. And Professor Mokris as well. Siehst du, auch beim Abdecken müssen wir wieder aufpassen, ne? Dass diese Referenzreflektoren zu sehen sind. Ich würde sagen, den schaltet man nur ein, wenn man wirklich brauchen. We can start? Okay, so welcome back everybody for the second part of this day, which is dedicated to rhino neurosurgery, to the approaches that in a four-handed technique shared by the neurosurgeon as the lead surgeon and one ENT surgeon through the nose, using the nose as a corridor to a variety of locations. Of course, this has started with pituitaries, but has gone well beyond, and depending on this cadaveric specimen's potential, we will try to demonstrate as much of that as possible. The arrangement that you see here in that room comes very close to reality. The patient's more or less flat on their back, maybe the upper body elevated some 10-15 degrees, if at all. And there are three at the table, the neurosurgeon, ENT surgeon, and the scrub nurse. The position is pretty much the same, similar. The instruments would be out of the way, behind the nurse. Anesthesia would be down there at the foot end, and because this would be another person competing for space. Instruments should only be passed in this triangle and never over the mid-face of the patient. We would have started precisely like we would for a standard FES procedure. That is, the patient is put to sleep, a totally gasless anesthesia, no anesthetic gases for the sake of bleeding, normothermia so that they don't cool down, which is very bad for the platelets and with that for bleeding. Talk about that tomorrow, etc., etc. The nose would have been lined in the very precise way like for standard FES, whether in a newborn or in a 90-year-old, with adrenaline swaps 1 in 1,000 for a minimum of 10 minutes for vasoconstriction, and then we would start as now. With a 0-degree telescope, we would enter the nose, and let me start on the patient's left side first. Again, looking for anatomy, inferior turbinate. This is the side that has not been operated on. Freer, please. And in this case, we would gently lateralize the turbinates, because we need to pass between the septum over here and the turbinate. This is not a problem because there is neither disease nor any surgery in the ethmoids. We take great pride in the fact that you do not have to resect turbinates, neither the middle nor the superior one, especially not in pituitary tumors. There are exceptions, of course, invasive macroadenoma, but we're not talking about these. Somebody has created a little septal perforation already, but that will help. Middle turbinate, superior turbinate, which I lateralize, and in reality I would now put in another swab with adrenaline just to maximally decongest the mucosa. Circular mushroom small. In this situation, however, the first step, and we've picked up this technique from Dr. Sethi, Singapore, who will be here tomorrow. We identify the natural sphenoidal ostium and we start to enlarge that maximally, because we would have best exposure of sphenoid, and we do that on either side. It depends again on the individual pathology of the patient, and of course this patient does not have any pituitary adenoma, but this patient has a massive brain and skull-based trauma with a lot of fractures. Could somebody please be as kind and switch on aspirator? Thank you. So, mucus and some blood, and we already start to get a good view into sphenoid proper. Cottle please, and suction off. Now, for closure of large defects, we may need a huge septal flap, which is based on branches of the sphenopalatine. If, therefore, we need to go further down, lowering the bony floor, before we do so, oh, sorry, the cottle, please. Did I say freer? My mistake. We need to take away the mucosa and the periosteum. Remember this morning how we demonstrated this sphenopalatine artery, which comes out here. And now we would like to avoid injury to its branches. So we fold down the mucosa, see, under the periosteum here, and we preserve those branches which cross over here, and possibly there. When we have to lower the bone of the floor of the sphenoid sinus. Okay, I would leave that as is, and this is pretty standardized for either side. And now here there was some surgery this morning already, very nice surgery by the way. And now I would do the same, gently lateralize middle turbinate, superior turbinate. Okay, we have another little breakthrough, and enlarge the sphenoid sinus ostium to the max on that side. There is no danger or risk involved with that, with one exception: if you go too far inferiorly, like I'm doing now, and causing a problem with branches of the sphenopalatine. But given the bipolar possibilities that we have nowadays, that should not be a problem. Aspirator on again. So let's get rid of this post-mortem or intramortem change here. Okay. The next step then, Sichel, would be the combination of those two ostia. And let me here palpate. Usually the bone can be very thick here, where the intersphenoidal septum passes into the nasal septum. And we will go about 7 to 8. Can we get rid of that? Thank you. 7 to 8 millimeters anterior to where the septum abuts to the rostrum, and go and cross over to the side. So I will use the sickle here. I turn it around and I go up. And that again depends on the individual pathology that we are going for. If we need to explore the planum sphenoidale and go further anteriorly, we can do so. We can reach as far anteriorly as the posterior table of the frontal. Now this resection of the septum does not at all interfere with the choana, which is down here. So we have nothing to do with the vomer, but we are high up. And now we continue, for instance, with a through-cutting Blakesley, and just follow that, taking it away in a stepwise fashion. Again, whatever instrument you may use for that is totally up to you. We have come to love this approach. Okay. Aspirator on, please. Wenn du möchtest, kannst du ruhig schon zu dir hinüberziehen, das Ganze. And can we briefly have the help of strong men, pulling the patient now a bit closer to our neurosurgeon. Now you can already from one side see both ostia. That's regardless where you have the endoscope and where not. And let me now start to connect the two. Straightforward through cut. Durchschneidend die normale, die wir gerade hatten. Okay. See, one of the advantages is I could do it from the other side as well. That is now totally, Professor Mokri might do it, whichever way you decide to work together. All that really works. It's very, very rare that you have to do a septum in combination with that. Now, Hayek downbiting, the large punch. You don't have it. Okay. Circular. No. Okay. Circular cutting large. So there are many possibilities. But the thick bone here in the center, sometimes you do not get away with just the with that circular cutting punch, which is not meant to be for such a thick bone. Ich nehme noch mal gerade durch. Ja, wunderbar. You don't have a downbiting one? Okay, so we have to improvise again. Which looks a bit weird. Okay. One side. Geht nicht so sehr gut. Ich nehme einen normalen im Seitenschneider, hast recht. Das ist wurscht. Ich kann von beiden Seiten reingehen. Okay, so here we could use the side biter and see what we do not like to use drills here routinely because all the dirt and debris around makes your field, despite irrigation, etc., look relatively ugly and congested with the bone dust, etc. Was wir aber machen könnten, we could prepare some irrigation here, just some water in a syringe as we had prepared yesterday with an irrigation device. But you start to see that we are getting closer here, and whether there is a deviation of the intersphenoidal septum to the patient's right side, whether you have other subsegmentations, is totally irrelevant for your orientation because you can see the anatomy now. Aspirator on again, please. Super. Danke. Ich brauche nochmal den Hayek, diesen wilden. Ich möchte das da unten noch wegnehmen. Danke. So, apologize, that's a bit of a makeshift thing. We don't have the right instrument. But we can do like that as well. Okay, now we have, ich nehme es nochmal, some access to the area, and maybe Professor Mokri can do what he usually does at that stage, telling me whether it is enough what I have resected for an approach to the pituitary. We routinely use navigation, it is there. We routinely use CT and MRI fusion. Ich sauge. And maybe somebody can provide the pointer to Professor Mokri to see how this works. We are not using optical navigation, but let's see what we can do here. Okay, you see the massive trauma. Okay, you see the massive trauma that this gentleman has suffered. Stand at Blakesley, straight.
Well, the microphone on. Microphone on. Switch off. No, this should be.
This is usually how we at home keep. This is usually how we at home keep our neurosurgeons silent. We don't switch on their microphone. No. No. I paid a lot for this, Michael. So in that, while they try to get, or hopefully somebody's trying to get the mic working, I do just some cosmetic work here to clean things up. You should be helping a bit with cleaning the instruments. That's the navigator. We don't need aspirator. Okay.
I try. Do you hear me? Hear me? Hear me? No, nothing.
Blakesley upturned.
Just before it worked. It should be on.
Battery gone. Can that be it?
Can you hear me? Hello?
Maybe you should.
Hello?
I'm the hanger.
Oh God.
Yeah. Test again.
Clean and back to me.
Can you hear me? 1, 2, 3, 4.
That's perfect. Oh, that's a beautiful one. Clean and back to me. Da liegt der Optikus schon frei oder die Dura.
No.
This is from the
Now it seems to work. Thank you very much. Excellent. Thank you very much. It's working.
Circular mushroom straight.
Okay, the cleaning of these multiple
And we like to show them, of course. No, that's important. Schaut, wie schön du das Chiasma siehst. Da ist es übrigens kaputt, ne? Von der Fraktur her, vom Trauma. Okay, das können wir mit dem Löffelchen. Auch da über der Karotis sind Brüche. Okay, das lassen wir mal, das müssen wir bohren, ne? Dann.
Well, so the next step will be to get oriented.
Better new batteries for the microphone than for the pacemaker. Okay. Ja, es kommt eigentlich alles sehr schön raus, ne? Circular. Reinige nochmal. And then side miter to the left, please. Side biter to the left. Michael, I believe this is sabotage. That's the backbiter, the one that goes to the side. I have it here. Sorry, my mistake. Maybe give me the one to the other side, with those to the left. Okay. So you see, this would be the way how you could lower now the resection margin of the septum, if there is need for it. I just tried to bridge the time a little bit. This would be how we can resect more of these intersphenoidal septations. And of course you might drill, but for reasons we've told you, we'd rather try to get along without drilling. And I think we can leave it as is now. Expose the floor of the cellar, but I think we have a beautiful display. While we are waiting for the microphone,
Two, it's working. X.
bist du sicher? Spielst du nur kurz rein? So you may wish, or maybe we can have one camera of the switch on. One of the cameras on our hands in front of the nose. Aspirator is blocked, like in real life.
Okay. That's the orientation. Up here, sphenoid, cellar floor. Down here, clivus. Up here, this is the border between cellar space and supracellar space. That is the place where the cellar diaphragm originates. That is our sagittal orientation. Up here, behind this bulging bone, there is... Oh, that's
now
a
you're there.
bit too loud. This is the frontal circumference of the optic chiasm, and here the left and the right optic nerve extends to the orbit. At this side, the patient had his head injury, basal trauma, the bone is fractured over here, and you already look at the dura covering the origin of the right optic nerve. Okay, to the lateral. Here is the optical carotid recess. That means that down here, the bulging of the left carotid artery is. The same on the left side. Optical carotid recess is a bit destroyed by the skull fracture. And below this additional septum, the right-sided carotid artery is located. So from here to the lateral, this is cavernous sinus. Again here, on this side, carotid artery. Maybe we can go in here.
A fracture as well.
As well as fracture. You're looking to the frontal circumference of the carotid siphon on the left side. So, in this specimen we don't have a pituitary adenoma. That means that the bone... Oh no!
You don't have
the
to
bone
drill.
should be a little bit thicker.
Normally,
We are lucky that it's not the case, because that spares us some drilling, and we can remove the bony floor of the cellar, exposing the periosteum of the cellar and the dura of the covering of the pituitary. Again, here we can use the circular punch, and it's very easy to remove the bone. And since we want to do it in a minimal invasive fashion, we have to adapt the approach to the needs given by the lesion itself.
That's the
whole
fracture,
thing
yeah.
is fractured. So I don't remove it at the moment, I leave it just to show what we can do here. So given the fact that we have, let's say, a microadenoma or an intracellular adenoma, then this approach already can be totally enough to get to the pituitary. One important thing is, over here, this dark area, that indicates the frontal intercavernous sinus. That's a connection between the right and left cavernous sinus. So, in cases of microadenomas, if you open up the dura, crossing the intercavernous sinus, you run into, in some cases, severe venous bleeding. And that's nasty bleedings, because if you coagulate here, the dura contracts and the bleeding might be more severe than before. So opening the dura of the cellar, just try not to go into the intercavernous sinus. In macroadenomas, normally that is not the danger, because the intercavernous sinus is obliterated because of the pressure of the tumor against the dura. So we can, if you look in here, we have a little bit more space for enlarging the approach to the cellar, to the lateral part. We see here the carotid artery on the left side. So I would suppose that the margin between cavernous sinus and intracellular space would be somewhere here. So if we have a macroadenoma, we can enlarge the approach to get more access to the tumor. Circular punch.
The circular small.
Circular small. Okay. Thank you.
And when you have learned to work together as a pair, you may wish to cross sides, because the person standing on the left side usually has a better access to the patient's right side in a situation like that, and vice versa.
The large one. Large. Yes.
Of course, here things move because of the fracture this patient has had.
And knowing where the position of the carotid artery is, and seeing that the dura beneath the bone moves with the instrument, so you are pushing away the dura, there is no danger to cut into the carotid artery. But you should see this. If you don't see it, it might be that you take a fold of the dura and maybe of the carotid artery into your instrument, and if you then cut through, then you run into a heavy bleeding.
This is a mobile phone interfering with the system here.
Okay. I will take this away.
Beautiful. Blake, please stand there for me.
So we can
Okay.
extend
It's okay.
already extend our approach. Well, now we are at carotid on the right. Here is some bone covering the left side, but I think here is the beginning, the medial part of the carotid over here. And again, intercavernous sinus, this is the origin of the cellar diaphragm, and up here the supracellular space starts. That means if you enter here, if you cut here through the dura, you run intracranially. That means you create a CSF leak. Down here, that's the bottom of the cellar floor. If we elevate the pituitary, we get to the back of the cellar cavity, and we stay at the clivus. This is the bony clivus, in this specimen very thick. So going down here, we should drill this bone away.
maybe at some later stage, or would you
Yes.
like to open first? While
We could-
Professor Mokri is getting the instruments, let's see how navigation might work here. I've dived into the cellar and I can feel the back wall of the clivus, and it's fairly precise. But you see at the same time, if you look now here onto my hands, if now I would like to use that during the surgical procedure and Professor Mokri would like to step in with his two hands and instruments, it doesn't work. You're in your own way. You lose the line of sight, and in addition to that, you lose the mobility of the instrument. So this is why we only use electromagnetic navigation for this. Again, this is nothing against the accuracy or precision of optical systems, but for this kind of surgical approach, you simply can't use it.
So jetzt soll ich
Das Schiebermesser, oder?
Bitte?
Wir haben dieses Schiebermesser auch, oder hast du es nicht
Ach so, ja.
rausgesucht? Ja.
Doch, das müssten
The pituitary, the dural knife, the one you can advance. No.
das
Nimm's, okay, ja, gut.
Well, assuming that we have a microadenoma, we cut into the dura over here. We know exactly here somewhere is the carotid artery, so don't start to cut here. Because somewhere here, over here, the origin of the left ophthalmic artery is hidden behind this dura. So the most lateral point I would cut would be this. I start here. We learned to do it in a U-shaped fashion. Because we can fold the dura back, hoping that maybe a CSF leak will not occur. And here we look into the intracellular space and look at pituitary tissue, and with curettes, like doing it with a microscope, and with aspirators and
Cup forceps.
cup forceps, we can remove tissue, tumor tissue. And you see here, if I cut in here, I hope there will come some blood.
Good chance for it. Well,
Uh,
yeah, okay. But that's the intercavernous sinus.
This is the intercurrent sinus, and we are looking from inside to the base of the cellar diaphragm, and over here, or it might already be
The stalk.
the stalk. Yes.
Yeah.
Well, that's parts of the diaphragm, and we are looking into the supracellular cistern that unfortunately is full of blood because of the head trauma.
Yeah. But maybe we get it out. Can I have the aspirator on again?
Some
Oder spülen, ja.
syringe. Soll man sich mal so weit machen lassen und dann. Nein.
Na, wir machen erstmal alles fertig
Okay.
und dann, die werden nie hinkommen da. Wir zeigen erstmal, was möglich ist.
Ich muss dann das Loch zuholen.
Ja. Achso. Geht das? Ja, ja, okay. Das bist du, ja.
We try to irrigate the area. Yes, this is
Yeah, yeah,
pituitary
yeah.
stalk, but we are below the level of the diaphragm, I have the impression. Look up here. Or this is the optic chiasm. Yes, this is the optic chiasm already. So we will extend our approach to the cellar tuberculum over here and to the sphenoid plane up here. Let's assume that we have, for instance, a craniopharyngioma that grows supracellularly up here, pushes the optic chiasm upwards, and the optic nerves to the lateral. So we go in here, but in this case, do we have a chisel?
Okay. Maybe I can in the meantime explain one thing that I love to hear. What they cannot do when they do pituitaries with the microscope, which has been done for decades, of course, was the gold standard. Here they have a marvelous view, which you could get in the microscope as well. But if I now retract the scope, I can show them with the movement of 2 of my fingers. This is the carotid, take care. There's the contour of the chiasm of the right optic nerve, right carotid artery, etc. We are not stuck to the midline.
That's not so good.
Ich möchte das noch ein bisschen wegnehmen. Just
I will show to you what the area of visibility is with the microscope compared to the endoscope. And I think this is one of the biggest advantages of the endoscope. With the microscope, with the speculum in the nose, you get an area of visibility of that size.
a bit larger
Some-
than the hole we have created.
Exactly. And only in rare cases you get a glimpse of the carotid of the optic nerves. You never will get up here unless you remove ethmoidal cells to push up the speculum, and you cannot get access to the lateral parts. Here you can go even further laterally to the cavernous sinus.
Machen wir dann alles noch. Ne? Können wir das da unten erst wegnehmen, ehe du nach oben gehst, oder heben wir uns das für später auf? Gut.
Okay. Yeah. Leave it.
So of course we cannot show a pituitary adenoma, as there is no adenoma, but especially the neurosurgeons will be more than familiar with the region up there, and you can beautifully see the optic chiasm, and behind that the stalk coming down. Soll ich da aufgezoomt lassen oder eher ein bisschen zurückgehen? So to give you a better anatomical overview, I will decrease the magnification whilst Professor Mokri is nibbling away bone of the planum sphenoidale. Now, the thing is we don't have the perfect instruments here for that. They still are hanging at some customs. So this is a bit of a makeshift procedure,
But it works.
but it works,
Of course you can drill this.
which we
But
might do as well. We
yes.
have a drill.
But it looks more clean.
This is the little round knife that we had. Okay, that's it.
Okay,
Ah,
that's
perfect,
working.
yeah.
That's working.
So we've started to expose the planum sphenoidale here.